Now our lecture today is inflammatory bone diseases. In the previous lecture, we discussed that the dental infection may spread to the soft tissues surrounding the jaws and appears clinically either in the labiobuccal vestibule or in the facial spaces surrounding the jaws. And this indicates that the jaw bones are more resistant to dental infection. However, sometimes when factors such as trauma and ischemia are available, in this case the infection may spread toward bone. And this is due to involvement of the medullary spaces. And this is due to the development of an inflammatory bone disease. The inflammatory diseases of bone include acute irregular osteitis, osteomyelitis and their types, acute osteomyelitis, chronic osteomyelitis, non-suppurative osteomyelitis, osteomyelitis of the maxilla, which is more commonly seen in children, and there is specific infection of the jaws. Actually, these are osteomyelitis, but with different causative microorganisms. Let us start with acute irregular osteitis. Acute irregular osteitis, or dry socket, which is most commonly used in the literature, or localized osteitis, or fibrinolytic irregularitis. Actually, fibrinolytic irregularitis is the most correct term used to describe this clinical condition. The dry socket is the most common complication of tooth extraction, in which the blood clot either partially or completely lost, or we can say the blood clot disintegrates or dissolves, lead to exposing the necrotic and infected socket wall. It is usually occur in the age group between 20 and 40 years old, and more common in the mandible than the maxilla, and this may attribute it to the type of bone. It is usually occurs after extraction of lower wisdom tooth, and more common seen in female than male, and this may attribute it to hormonal differences. After tooth extraction, the socket filled with blood due to severing of the blood vessel with the periodontal ligament. The blood clot is very important. The blood clot protects the socket from food debris and also from contamination with the oral environment, and also prevent food impaction. In addition, it stops bleeding. But if the blood clot does not form or lost for certain reason, this will lead to the development of severe pain. This condition is called dry socket or localized osteitis. The pathogenesis, if we use excessive force or traumatic extraction, this will lead to release of tissue activators, which is found within the alveolar bone. The tissue activators convert the plasminogen within the blood to plasmine, and the plasmine lyses the fibrin threads of the blood clot and lead to partial or complete loss of the blood clot, leading to the formation or establishment of dry socket. The etiology of dry socket could be divided in general into vascular component or infective component, or infection or infective component. The physical dislodgement of blood clot due to the patient use excessive rinsing of mouth, and this will lead to dislodgement of the blood clot. Or second stroke, or sometimes due to smoking. The negative pressure during smoking dislodges the blood clot. So this will lead to the development of dry socket. Or sometimes the tooth is already infected with periapical infection or pericornitis. So the possibility of developing dry socket after extraction is very high. In addition, certain types of bacteria such as fusiform bacilli, diplococci, streptococci have been isolated from the socket affected with dry socket. Traumatic extraction, as I explained before, this will lead to also establishment of dry socket. Local blood perfusion and anesthesia. Some people said that the region of lower wisdom tooth is poorly supplied with blood in comparison to other regions of the mandible. And this may explain why the extraction, or why after extraction of lower wisdom tooth, the incidence of dry socket is very high. However, other people said that the region of lower wisdom tooth is rich to blood supply, or has better blood supply in comparison to other regions of the mandible, such as the incisor region. The type of anesthesia. Actually, the local anesthesia contains vasoconstrictor, and vasoconstrictor inhibit the inflammatory component. That means the blood supply to remove the necrotic tissue, the dead bacteria. Actually, the vasoconstrictor reduce the blood supply, and this inhibits the formation of blood clot and subsequently lead to development of dry socket. In addition, some people said that the incidence of dry socket after extraction under local anesthesia is very high, while there is no or very little incidence of dry socket after extraction under general anesthesia. Excessive irrigation and curettage of the alveolar socket after extraction. Excessive irrigation, actually, this may interfere with wound healing because whenever the blood clot forms, the irrigation remove or dislodge the blood clot and interfere with wound healing. Curettage of the alveolar socket, actually this will lead to obliteration or occlusion of the blood supply found within the floor or the wall of the socket, and this reduces the blood supply and subsequently or eventually lead to establishment of dry socket. Smoking has two components. The negative pressure during the smoking dislodges the blood clot, and nicotine as chemical factors, because nicotine reduces the amount of the blood supply reaching to the socket, and this leads to inhibition of blood clot formation and establishment of dry socket. Oral contraceptive pills, actually this contains estrogen, and estrogen may act to stimulate the fibrinolytic system, and this is lyses the blood clot, lead also to establishment of dry socket. For roots or bone fragments, actually there is no scientific evidence suggests that the roots or bone fragments may lead to development of dry socket, but this may interfere with the wound healing. Poor oral hygiene, periodontitis, or acute gingivitis, this may also participate to certain extent for the development of dry socket after tooth extraction. The clinical feature of dry socket, first of all, there is dull or severe pain, particularly after 2 to 4 days of tooth extraction. Actually, this point is very important from diagnostic point of view. Usually, the pain starts after 2 or 4 days after extraction. To diagnose the condition, this is very important. Pain may radiate to ear or temporal region, swollen and red gingival margin because there is inflammation, bad odor or taste. This is because of the fragmentation of the food debris impacted or trapped in the socket. Socket devoid of blood clot, bone is bare and sensitive to touch. This is because of exposure of the nerve endings. Food debris trapped in the socket. There is also enlargement of localized lymph node, or what we call lymphadenopathy. The management could be surgical or non-surgical. The non-surgical, which is very important, includes irrigation with warm normal saline. This is to remove food debris, disintegrated blood clot, and to initiate bleeding so that for the formation of a new blood clot. Medicated dressing, usually sympathetic dressing, which is alpha-gel actually is the most common dressing used nowadays. This contains anesthetic, analgesic, and antimicrobial agents. It is very effective. The patient may be given also potent analgesic or non-steroidal anti-inflammatory drugs to reduce pain. Metronidazole 400 mg 3 times daily for 5 days if there is infection. Nowadays they use photodynamic therapy, or what we call little laser therapy. This is to stimulate wound healing. And also plasma-rich fibrin, actually this is give good result to reduce the time for healing of dry socket and even to reduce the onset of pain actually, or the severity of pain also may be attributed. The surgical treatment includes removal of the stitches if there is a stitch or if there is stitches, and also trimming of the bone margin, and also trimming of the necrotic gingival margin. Sometimes we can do also gentle curettage of the floor of the socket, but this is actually not advisable since this may lead to aggravate the condition. So this is the end of the lecture, and thank you for your attention.